Θα κάνω τη διάλεξή μου στα αγγλικά και μετά μπορώ να κάνουμε τη συζήτησή μας πάλι στα ελληνικά. Αυτά είναι τα conflicts of interest. So what I'm going to address is three things. I'm going to address how to interpret lateral T-wave inversion on the athlete's ECG, which is a subject that can cause a lot of confusion. Then I will highlight how do you go about investigating and following up such a case, and I'm going to illustrate it through a case I'm going to present to you. And then we will discuss the value of detraining, which is what I was asked to do. So in terms of the athlete's ECG, it's very, very important to understand that it's not just the exercise that may influence the ECG, but also the different demographics, sporting discipline, the gender, as well as the age of the athletic individual. And it's evident that those athletes depicted here cannot have the same cardiac adaptation. And why is it important that we're aware of what happens to the 12-lead ECG? Because it's the main screening tool that we use in sports cardiology and pre-participation screening in order to differentiate between physiology and potential pathology that requires further evaluation. Now, in terms of the ECG recommendations for the interpretation in athletes, we've got the international recommendations that were published in 2017, and we will probably have some new recommendations in 2025. And in terms of T-wave inversion, what they do is they exclude lead V1, they exclude lead 3 and lead AVR, and then they consider pathological T-waves, any T-wave that is in the same territory, anterior, inferior, and lateral. Usually they require at least 2 consecutive leads. So for the anterior territory, for example, we need to have an abnormal T-wave inversion in V2 and V3. So the ECG I'm depicting here will be considered as normal as we don't take into account V1. For the inferior will be 2 and AVF. For the lateral territory, they make an exception given the importance, and even a single T-wave inversion in lead V5 is considered abnormal and require further evaluation. Now, this is a typical ECG of a 35-year-old amateur runner, which was identified during a pre-op assessment, actually, that will cause concern. And you've got clear T-wave inversions that affect predominantly the lateral leads. The depth is more than 1 millimeter, and they extend in 1 AVL, V4 to V6. This is another ECG that will cause a lot of concern, and even more than the previous one, because here you've got extensive T-wave inversion that affects the lateral, the inferior, and the anterior leads. And in this particular case, also you've got an upward AVR and associated ST segment depression with the deep T-wave inversions in the lateral leads. And beyond that, if you're careful and you look at your leads V1 and V2, you will see that you've got some pathological QAs. And when you look at such an ECG with such widespread T-wave inversions with high QRS voltages and ST segment depression, the first thing I think is it possible that this is apical hypertrophic cardiomyopathy? And the reason because I say that is because if you think about it, then you will take a better look at your echocardiogram, try and open up your apex and look at the apex in a lot of detail. And in this particular individual, as you can see from the echocardiogram and the cardiac MRI, there was a fairly severe form of hypertrophic cardiomyopathy, which affects the mid and apical segments with significant myocardial fibrosis on the cardiac MRI. However, and it's important to remember that things can be far more subtle than the ECGs I showed you before. This is a nice example of a 28-year-old elite rugby player that he came for a cardiac screening completely asymptomatic with no family history. And you could potentially identify here that leads V4, V5, they look a bit biphasic, they don't look quite normal. And the question is, would you actually investigate him further? Would you just do a transthoracic echocardiogram? Or would you consider it as a biphasic T-wave and leave it alone? And I hope that the answer is that you will do another echocardiogram. And indeed, we did one and there was nothing there, and he was not referred for further evaluation. But then if you look in 2012, when he came back for a screening, you will note that now the T-wave inversions that were subtle beforehand in V4, V5 are clear deep T-wave inversions that affect leads V4 to V6. And at that point, he had developed a hypertrophic cardiomyopathy phenotype on his transthoracic echocardiogram. Now, why do we worry about lateral T-wave inversions? We worry because they are associated with cardiomyopathy phenotype. So it's quite a common finding in cardiomyopathy, such as hypertrophic cardiomyopathy, but even dilated and arrhythmogenic cardiomyopathy. And they're not usually a feature of athletic adaptation to exercise. Now, if you look at this particular study from our Australian colleagues, where they studied very elite endurance athletes and athletes from other competitive disciplines. And this has been highlighted in other studies as well, that if you look at anterior T-wave inversions, and here I've got a typical ECG for you, you could potentially find T-wave inversions in leads V1 to V3, which are usually associated with a J-point elevation and a convex ST segment elevation, and they're more frequent in athletic compared to sedentary individuals. And the higher the level of athletic activity, the greater the frequency of those T-wave inversions. However, if you look at the inferior and lateral leads, there is no correlation with athletic activity. And in the bibliography, you will usually find that lateral T-wave inversions are present in less than 1% of athletic individuals. And we know that if you go and investigate comprehensively lateral T-wave inversions, and this is our experience from 100 athletic individuals, 50 black athletes, 50 white athletes, and you'll see that we investigated anterior, inferior, and lateral T-wave inversions, and by far the greater diagnostic yield of an underlying heart muscle condition is in the lateral T-wave inversions, where in the black athlete group it was about 20%, while in the white athlete group it was about 56%. And that makes sense because we know that for black athletic individuals, the prevalence of lateral T-wave inversions can be up to 4%. So they exhibit them more frequently than white athletes, where I told you it's less than 1%. And therefore, the diagnostic yield tends to be less. That means, obviously, that some of those lateral T-wave inversions do not signify pathology, but given how high the diagnostic yield, we cannot afford not to investigate them. And this is the systematic approach that I usually take for lateral T-wave inversions. I think it's important that you start from the very basic in terms of demographics, the history, the physical examination, then go to your first-line investigations such as echocardiography, exercise testing, prolonged ECG monitoring. Cardiac MRI nowadays has become routine in the investigation of those athletic individuals. And then we need to consider familial evaluation. And I will refer also to detraining and genetic testing that needs to be performed with some caution. And we've got data not only from our study, but from other studies as well, from Antonio Pelliccia, from Frédéric Snell in France, that clearly highlight the diagnostic yield of investigating lateral T-wave inversions. And as I said, that's why I would strongly encourage you to investigate athletic individuals with such ECG anomalies fairly comprehensively. Now, let's show you a case of a 20-year-old football player. He's of Nigerian descent, who comes to a pre-participation screening with no symptoms, past medical history or family history. Now, this is the ECG of this particular athlete, and you can immediately see that he's got fairly widespread T-wave inversions that affect the anterior, but cross the V3, V4 that we may tolerate in black athletes and go to V5, V6, and also affect your inferior leads. Now, this athletic individual will require further evaluation, And if we go to his transthoracic echocardiogram, you will note that he's got some mild hypertrophy, potentially at the base, and I'll show you the measurements in just a second. His left ventricular cavity seems reasonable because, as we know, in pathological states, we get concentric hypertrophy rather than eccentric hypertrophy of exercise. However, it's important to remember that up to 20% of black athletes exhibit concentric hypertrophy. And in your four-chamber view, you're able to see that the apex looks reasonable, but perhaps there is a bit of apical displacement of your papillary muscle. And these are the measurements from the transthoracic echocardiogram, and they measured the septum and the posterior wall about 13 millimeters. You need to be careful not to include your right ventricular trabecula, and you can freeze it and freeze it and do your best to do that. You see that he's got a reasonable cavity of 55 millimeters, and he had normal indices of diastolic and also of systolic function, with his GLS being a bit varied, but roughly within acceptable limits. Now, for this particular individual, we went on to do a cardiopulmonary exercise test where he achieved a workload of almost 270 watts. You see that his peak VO2 is 45 mL per min per kilogram, which is about 95% of his predicted. So not necessarily as good as I'll expect it to be in an athletic individual, but partly that may also be because we put him on a cycle ergometer rather than a treadmill test. He's got a good blood pressure response to exercise. Some may consider it a bit hypertensive, but we, in athletic individuals, usually, depending on the workload as well, we accept anything up to 220 millimeters of mercury. Importantly, there was no arrhythmia during exercise testing. And we went on to perform an ECG monitor, and you can clearly see that there is no evidence of arrhythmia whatsoever. The one thing to highlight, you can see that the maximum heart rate was about 130 beats per minute, which probably means that this athletic individual did his Holter without training or exercising. And that's part of the limitation of being assessed in our national health system as well, because we've got the old-fashioned monitors rather than the patches that athletic individuals can use when exercising. And then we went on to perform a cardiac MRI, and what the cardiac MRI said to us, and you can see the short axis stat, that there is a bit of hypertrophy, about 14 to 15 millimeter in the septum. The cavities are dilated, which is a good sign. And most importantly, there was no evidence of myocardial fibrosis, so there was no evidence of late gadolinium enhancement. And you may consider 1340 millimeters as very high, but the reality is that we know that up to 12% of athletic individuals of black descent may have wall thicknesses close to 13, 14, and sometimes even 15 millimeters. So the question here is, what do you think this represents? Is this athlete's heart? Is it a morphologically mild or incomplete expression of hypertrophic cardiomyopathy? Or is it even possible that the stresses of cardiac load associated with exercise have exposed the concealed hypertrophic cardiomyopathy phenotype? Now, regarding family screening, I tend to perform family screening with a simple ECG and echocardiogram because obviously if this is hypertrophic cardiomyopathy, it has significant implications for the first-degree relatives. And in this particular case, we were able to get hold of his mother and sister who both have an unremarkable ECG and transthoracic echocardiogram. The next question that usually comes along is, should I do genetic testing? Should I get a panel for hypertrophic cardiomyopathy and test that individual? And we test that concept in the study I showed you earlier on 100 athletic individuals with T-wave inversions. We diagnosed 21 based on clinical evidence. And out of those who had clinical evidence of cardiomyopathy, then the genetic yield was high, about 38%. On those, however, who did not have a clinical phenotype beyond T-wave inversions, the diagnostic yield was only 2%. And I can tell you that the pathogenic variants were identified were more confusing rather than presenting us with solutions in terms of the underlying cardiac diagnosis in those individuals. So handle genetic testing with care. Now, what did we do with this particular individual? Well, we said we don't have enough to label you at this point with a cardiomyopathy, but we need to keep an eye on you. Why do we do that? We do that because we know that if you keep an eye on those individuals, then you may potentially add another 10% in your diagnostic yield in the next 5 to 10 years. Now, he remained completely asymptomatic and he came back after 6 months. What happened, however, is that he had detrained not because we instructed him, but because he had an injury. And that was his 12-lead ECG now, okay? And you can see that the lateral T-wave inversions have completely resolved. And if I put them side by side for you, you will note that the T-wave inversions that were prominent before in the anterior, inferior, and lateral leads have resolved upon detraining. And on repeat echocardiography, the 13 millimeters that we're finding before had become about 12 millimeters, allowing obviously for the limitations of such small differences in measurement. So the question now is that actually athletic adaptation to exercise? And this is a similar case that was presented in the literature many years ago. The reason why I'm showing you this case is because it starts with a similar sort of ECG with a wall thickness of 15, 16 millimeters. And in this particular case, they did a myocardial biopsy and they proved myocardial disarray. So he's got hypertrophic cardiomyopathy. But with detraining, the ECG completely normalized. And then when he started to train again against their doctor's advice, he went back to his original ECG. So my message here is with detraining, if it does not resolve, it is probably pathological. But if it resolves, don't consider that it's necessary physiological. So in conclusion, lateral T-wave inversions are a common phenotypic feature of cardiomyopathies and relatively rare in athletic individuals. And I also want to highlight that they're very rare in female athletes. So if you see lateral T-wave inversions, you're probably onto something. A bit more common in black athletes, and that's why the diagnostic yield is a bit lower. They should be investigated comprehensively, and I demonstrated to you here the armamentarium of investigations we've got available with caution relating to detraining and genetic testing. Isolated T-wave inversion is not a diagnosis and is definitely not a reason to exclude someone from exercise. So please avoid labeling individuals unless you've got a high degree of certainty. And I also highlighted the fairly limited role of detraining because of challenges detraining, particularly elite athletic individuals, but the uncertainty that exists even if those T-wave inversions resolve. And if you're interested in sports cardiology, definitely have a look at the MSc that we run at St. George's University of London. The conference that we're planning, and register your interest through this barcode in London, where you can attend face-to-face or remotely, and the ESC Preventive Cardiology that we'd love to see you in Milan between the 3rd and 5th of April. Thank you very much for your attention.
Thank you. Ευχαριστούμε, Μιχάλη, πραγματικά. Όπως πάντα, με ιδιαίτερο ενδιαφέρον και με πολλά σημεία που μπορούμε να χρησιμοποιήσουμε στην καθημερινή πρακτική. Θα ήθελα να παρακαλέσω τους συμπροέδρους, αν υπάρχει κάποια ερώτηση από όσους είναι στο ακροατήριο, να απευθύνω. Εγώ θα ήθελα ένα σχόλιο για ένα κομμάτι, μισό λεπτό Δημήτρη, Γιάννη, για ένα κομμάτι που ανέφερες. Σε αυτούς που έχουν αρνητικά τάφ που ξεκινήσαμε τον έλεγχο, χωρίς να υπάρχει τίποτα από τον φαινοτυπικό έλεγχο τον υπόλοιπο, φαντάζομαι μαγνητική, υπέρηχο και μαγνητική, μας είπε σε ένα ποσοστό 2-2,5%. Αν προχωρήσει σε γονιδιακό έλεγχο θα έχει κάποιο προβληματικό ή κάποιο γονίδιο που πρέπει να το σκεφτείς. Ποια είναι η σημασία αυτό? Γιατί έτσι όπως το κατάλαβα, σε όλους αυτούς, αν μετά το αρχικό ο φαινότυπος από την απεικόνηση δεν έχει κάτι ιδιαίτερο, από το οικογενειακό επίσης δεν έχει, πότε θα προχωρήσουμε σε γονιδιακό έλεγχο και πώς θα αξιολογήσουμε σε κάποιον με αρνητικό φαινότυπο το γονιδιακό έλεγχο. Θα μπορούσα να το καταλάβω αυτό σε κάποιον που είναι professional athlete και πρέπει να πάρει μια απόφαση. Σε όλους τους υπολείπους, εμείς καθημερινά μπορεί να δούμε κάτι, πώς να το αξιολογήσουμε.
Αυτό ακριβώς ήθελα να επισημάνω, κύριε Φιλιππάτο, ότι το διαγνωστικό yield είναι πολύ μικρό και στη δική μας περίπτωση ήταν και πολύ confusing, δηλαδή δεν ξέραμε τι να κάνουμε με τα αποτελέσματα. Όπως είδατε, είχαμε μια likely pathogenic variance στο ACN5A, το οποίο συνδυάζεται με long Q3 Brugada, και είχαμε και ένα στο transthyretin, το οποίο δεν ξέραμε ακριβώς τι να κάνουμε στο συγκεκριμένο ασθενή. Οπότε το μήνυμά μου είναι ότι αν δεν έχουμε φαινότυπο πέρα από τα T-wave inversions, θα πρότεινα να αποφεύγουμε το γενετικό έλεγχο. Πρέπει να υπάρχει, όπως είπατε, κάτι στον ίδιο ή κάτι στην οικογένεια για να προχωρήσουμε.
Ευχαριστώ πολύ. Δημήτρη, κύριε Τziakas, κύριε Παρίση.
Κύριε Παπαδάκη, ευχαριστούμε πάρα πολύ. Πάρα πολύ. Ξέρετε, το συνηθέστερο πρόβλημα στα καρδιογραφήματα που αντιμετωπίζουμε στους αθλητές είναι τα αρνητικά κύματα τάφου. Όπως προφανώς και εσείς. Εγώ ήθελα να ρωτήσω, επειδή είμαστε λίγο συντηρητικοί, εφαρμόζουμε το Detraining, γιατί δεν είναι και τίποτε ποδοσφαιριστές σε ομάδες αλφαεθνικής, αλλά είναι παιδιά που ασχολούνται, παίζουν σε ερασιτεχνικές ομάδες. Και στις πλήστες των περιπτώσεων βλέπουμε ότι τα αρνητικά κύματα τάφου μετά από 3 μήνες ή και λίγο παραπάνω πραγματικά αποκαθίστανται, σαν αυτό που μας δείξατε. Κάποιοι όταν ξαναρχίζουν πάλι αρνητικοποιούνται τα τάφ κύματα. Τώρα αν αυτό είναι κάποια μυοκαρδιοπάθεια που η παρατεταμένη άσκηση την αποκαλύπτει, δεν ξέρω να απαντήσω. Αλλά κάνω μια ερώτηση έτσι απλά για να μου απαντήσετε. Εάν έχουμε έναν αθλητή με το τελευταίο που μας δείξατε με τα αρνητικά κύματα τάφ στις πλάγιες απαγωγές, είναι ασυμπτωματικός, έχει πολύ καλό performance στην καρδιοαναπνευστική κόπωση, δεν έχει οικογενειακό ιστορικό, κάνουμε και μαγνητική και είναι απολύτως φυσιολογική, νομιμοποιούμαστε να τον αποκλείσουμε από το competitive sport? Είναι όλα φυσιολογικά και μαγνητική. Αλλά τα αρνητικά υπάρχουν.
Ευχαριστώ πολύ, κύριε Φημιάδη. Σε καμία περίπτωση είναι η απάντηση. Ο συγκεκριμένος αθλητής καταρχάς δεν πρέπει να τον αποκαλούμε ασθενή. Το μόνο που θα έκανα ήταν να τον φέρω πίσω για επαναληπτικό έλεγχο, όχι απαραίτητα με τη μαγνητική, για να είμαι εντελώς ειλικρινής. Εγώ αυτό που κοιτάω κυρίως είναι το καρδιογράφημά, το υπέρηχός του και ψάχνω αριθμία. Η αριθμία είναι πάντα που με ανησυχεί. Εξαρτάται από πόσο ανταγωνιστικό άθλημα κάνει και ποια είναι και η ηλικία του συγκεκριμένου αθλητή. Κάθε πότε θα τον φέρνω και αν η παρακολούθηση θα είναι κάθε 1, κάθε 2, κάθε 5 ετία. Προφανώς το καρδιογράφημα που σας έδειξα στο συγκεκριμένο αθλητή, αν ήταν 16 χρονών, είναι διαφορετικό το σενάριο από το αν ήταν 32 χρονών.
Ευχαριστώ πολύ.
Ο κύριος Κώστας, θέλει να ρωτήσω όμως.
Ευχαριστήρια, Μιχάλη. Εξαιρετική παρουσίαση. Και εξαιρετικό και το μήνυμα ότι ένα abnormal ECG δεν είναι reason to exclude a patient, είναι reason to do the workup. Η ερώτησή μου είναι απλά, βλέπουμε πολλούς τέτοιους αθλητές οι οποίοι έχουν αυτή την υπερτροφία, έχουν ένα ανώμαλο καρδιογράφημα, δεν έχουν τίποτε φυσιολογικό στο υπόλοιπο workup. Έχετε δεδομένα μήπως σε βάθος δεκαετίας, ας πούμε, πόσοι από αυτούς εν τέλει ανέπτυξαν φαινότυπο μυοκαρδιοπάθειας και πόσοι απλά παράτησαν τον αθλητισμό και υπέστρεψαν σε σχετικά φυσιολογικές καρδιές?
Εγώ δεν έχω δεδομένα από το δικό μας cohort. Απλά τα δεδομένα που υπάρχουν από τη μελέτη που είχε κάνει ο Αντώνιο Πελίτσια, ο οποίος έδειξε ότι σε βάθος δεκαετίας μπορεί να έχεις ένα additional yield γύρω στο 5 με 10%. Αυτό είναι. Οπότε, βέβαια εξαρτάται, όπως είπα πριν, από την ηλικία, γιατί προφανώς ένας adolescent είναι εντελώς διαφορετικός από ένα 25χρονο, 35χρονο ή 45χρονο. Αλλά αυτό που θα έκανα είναι ότι κάνω τον έλεγχό μου time zero. Εάν είναι αρνητικός, είναι αρκετά reassuring, γιατί οι πιθανότητες να βρεις κάτι αργότερα είναι μικρότερες. Αυτό που είναι σημαντικό για μένα είναι να μην ξεχνάμε την οικογένεια, γιατί όπως υπόθηκε και από άλλους ομιλητές που άκουσα προηγουμένως, μπορεί να έχεις, όπως γνωρίζουμε, 10 άτομα στην ίδια οικογένεια, τα οποία να έχουν τον ίδιο γονότυπο και να έχουν εντελώς διαφορετικό φαινότυπο. Οπότε το γεγονός ότι έχουμε ένα αθλητή ο οποίος έχει lateral tube inversion, μια υπερτροφία, δεν σημαίνει απαραίτητα ότι δεν υπάρχουν άλλοι συγγενείς που πιθανότατα να έχουν ένα εντελώς διαφορετικό φαινότυπο και ένα εντελώς διαφορετικό ρίσκο.
Ωραία, ευχαριστούμε πάρα πολύ. Συνεχίζουμε με τον Μπάμπη τον Βλαχόπουλο, ένα εξαιρετικό φίλο, ο οποίος διευθύνει το ΕΚΑΝ